Legalities, Part 2. Privacy in health care involves the right to govern bodily integrity and the right to control when and how sensitive information is shared. There's laws that require reporting of certain patient information even without the patient's consent, and the purpose of this is to protect the public. The American Health Insurance Portability and Accountability Act, or HIPAA, rules took effect on April 14, 2003 for health insurance companies, hospitals, clinics, doctors, pharmacies, and other health groups throughout the United States. It provides protection of privacy, a guide for health-related facilities and individuals to establish privacy standards. The goal was to reduce paperwork related to healthcare reimbursement and to establish security standards for the protection of electronic, computer or fax transmission of protected health information. It is intended as a national privacy standard throughout the entire United States. So in discussing privacy, HIPAA uses the term protected health information, or PHI, when referring to patient information that should not be revealed. Patient rights in all types of situations or institutions are mandated by the United States Constitution and by state and federal laws. Legal rights might vary depending on the setting and the individual's competency. If a patient is incompetent, state laws are followed, and this usually means that the patient's health proxy is treated as though he or she is the patient. The Joint Commission has been reviewing adverse incident studies on causes of serious harm and death to patients since the mid-1990s. The Institute of Medicine's 1999 study estimated that 44,000 to 98,000 Americans die every year as a result of medical errors. High on that list of errors is medication error. Improper patient identification is often a problem in giving medication and also in doing wrong site surgery. Let's look at patient competency. Legal competency is considered to be 18 years old or older. But if they're under 18 years and they're pregnant or married, if they're a self-supporting minor, they are considered to be competent in the eyes of the law. Clinical competency refers to a patient who is able to do the following. They can identify the problem for which he or she is seeing the physician. They understand the options for care and the possible consequences. They can make a decision and provide sound reasons for the option that he or she chooses. General consent or implied consent is the fact that a person has voluntarily sought admission to a healthcare agency and willingly signs a general admission form. Informed consent must be obtained for invasive procedures that are ordered for therapeutic or diagnostic purposes. The patient must indicate comprehension or understanding of the information provided. Informed consent, the risks, the benefits of receiving the treatment, the risks of not receiving the treatment, alternative treatments, etc., must be provided to the patient prior to them signing informed consent, and it should be provided by the person who is planning to perform the procedure. So in other words, the surgeon or the physician. It is okay for the nurse to go ahead and then witness the patient signing the consent, but I usually ask and make sure that they don't have any additional questions prior to signing the consent, and making sure that they are signing the consent that they think they should be. Authorized consent is where parents cannot give informed consent for the treatment of their children, but they can authorize treatment for their children up to a certain age. Implied consent is most often encountered when a patient enters the hospital, again, and signs that general admission form. Remember that the patient has a right to consent to or refuse treatment, and that is an aspect of patient autonomy. Nurses are required to ask about advance directives on patient admission to a facility. So nurses need to be familiar with the terminology in order to explain it to the patients. Again, the Caring Conversations workbook may be beneficial for clients. And remember that the Caring Conversations workbook is easily found online. A copy of a patient's advance directives should be placed on the patient's medical record, and it basically stays there until it is overridden by a new advance directive. Nurses should strive to uphold advance directives. Unfortunately, it's not always possible, but we should always try. The Patient Self-Determination Act is an amendment to the Omnibus Budget Reconciliation Act, or the OBRA. It requires Medicare and Medicaid providers to give patients information about their rights, such as the right to participate in and direct their own healthcare decisions, the right to accept or refuse medical or surgical treatment, the right to prepare an advance directive, information on the provider's policies that govern the utilization of these rights. A living will is a legal document that describes the kind of medical treatments or life-sustaining treatments the person would want if seriously or terminally ill. It can also describe what they don't want. It does not let the person select someone to make decisions for them. A durable medical power of attorney names a healthcare proxy, and this can be anyone that is at least 18 years old to make medical decisions if that person is no longer able to speak for him or herself. It becomes active anytime the person is unconscious or unable to make a medical decision. So in other words, if a person has a durable medical power of attorney, it doesn't mean that the person they have appointed to be their proxy can just make any decision for them. It only goes into effect if that person is unable to make decisions themselves. Institutions, again, ask for these documents upon admission, and neither of these documents is the same as a do-not-resuscitate order. A good advance directive will describe the kind of treatment that is desired by the person depending on how sick he or she is. And again, the advance directive usually will indicate what type of treatment is not desired. However, it can also indicate that the person wants all possible measures used to prolong life. A do-not-resuscitate order, or a DNR, is an advance directive that provides legal permission for a physician to write a DNR order. The physician can also write a DNR order for a patient who no longer has decision-making ability but does not have personal advance directives written and signed. With the removal of life support systems, the physician must pronounce the patient dead and document the status before the nurse turns off the ventilator. If the nurse removes a life support system before the physician pronounces the patient dead, it can be considered an act of murder. Physician-assisted suicide refers to a physician providing the means for death, most often with a prescription. The patient not the physician, will ultimately administer the lethal medication. The Oregon Death with Dignity Act allows terminally ill Oregonians to end their lives through voluntary self-administration of lethal medications expressly prescribed by a physician for that purpose. Now, there are a few other states other than Oregon that have also instituted that type of policy, but Oregon was the first one. Euthanasia generally means that the physician would act directly, for instance, by giving a lethal injection to end a patient's life. Organ donations are voluntary. Body tissues that can be donated include skin, corneas, bone, heart valves, and blood. Organ donation has raised both ethical and legal questions in some instances. Unfortunately, organ donation is currently a crisis situation with demand far outstripping availability. Numerous organizations and projects work on end-of-life principles. Adopted or support core principles for end-of-life care. We look at the term palliative care because it's used to identify the wide range of clinical services available for patients whose disease is not responsive to curative treatment. The Good Samaritan Act liability often includes the stipulation that once care is begun, it cannot be abandoned unless the person is unable to continue performing the care due to exhaustion, for example. The state statutes are of special concern to nurses and physicians who provide emergency care outside of the agency that employs them. The LPN must have permission to treat the person, and verbal permission must be obtained from the victim, and that person does have the right to refuse. Of course, if the person is unable to provide permission, then permission is implied. There's many types of acceptable documentation. Remember to chart only objective comments, not subjective. Objective being what you see, subjective being what you say. Subjective comments can become legal ammunition in a lawsuit. If you document any type of subjective documentation, it must be in quotes. The patient states, and then put it in quotes, and it needs to be as exact as possible. Remember that the more professional the documentation, the better a reflection it makes on the nurse in a legal action. When documenting late entries, they have to be labeled with the actual time that they're written. Verbal orders should always be avoided whenever possible. A nurse can be considered practicing outside the scope of practice if he or she gives advice to friends or family. The nurse is responsible for actions performed by an unlicensed assistive personnel that he or she supervises. The nurse should never document care given by someone else. The nurse should know the institution's policy regarding correcting entry errors. White out or completely crossing out an entry is an unacceptable way to correct errors. If a physician's order is illegible or questionable, you have a duty to clarify the order with the physician. Telephone triage and advice is often an overlooked area of legal liability. Institutions and physicians' offices should have well-researched procedures for documentation of telephone triage or documentation. Basically, if someone calls in for information or advice, you should not give it over the telephone because you could be held legally liable. When taking telephone orders, only a nurse can do so. Patient education is also an often overlooked area of legal liability. Documentation of teaching is frequently inadequate unless the nurse also documents the patient's understanding level. Remember that incident or variance reports are not to be included or referred to within a patient's medical record. They are designed to report any incidents outside the normal realm of a facility's function. In other words, a fall, an injury, malfunctioning equipment, patient outcomes outside expectations, etc. Investigate issues that may require change, and it helps with that investigation, and it creates a paper trail to support necessary changes.